Okay, friends, I'm starting. Hope audio video is okay. Yes, let me see the link also if everything is okay. Yeah, okay, fine. Okay, there's no technical hitch. Let me see. Okay. So I'm Dr. Ajay Yadav, Anesthesia faculty at DBMCI. So let's start your recall questions. I could manage to get only 5 anesthesia questions. However, the questions were actually pretty simple and easy. So we'll go through the discussions and whatever queries you have, and if you feel that there was the question in actual was different from what I've collected here, so just let me know. So all those discussions we will have at the end of discussion. Okay. So question number one. A patient undergoing general anesthesia develops left lung collapse following intubation. On auscultation, breath sounds are heard only on right side. What is the most likely cause of this condition? Right endobronchial intubation, mucus secretion obstructing the endotracheal tube, pneumothorax on left side due to positive pressure ventilation, bronchospasm. It's very straightforward question. You are not hearing any breath sounds on left side. What does that mean? That means the tube has slipped into right bronchus, and whether it's a foreign body or endotracheal tube, it always slips into right bronchus by default, because you know that angle of right bronchus is more obtuse as compared to left side. That's why foreign body aspiration also happens on right side. So endotracheal tube also get clipped on right side. So if it gets slipped on right side, and you know that is how we confirm the intubation. What are the ways to confirm the intubation? A very simple way is auscultation. We auscultate, and if you find air entry equal on both sides, that indicate that the tube is in trachea and is in right place. But even auscultation can misguide you. Sometimes the tube may be in esophagus and you are hearing the conducted sounds which you can misinterpret as breath sounds. So therefore, confirmation, 100% confirmation of intubation is only possible with capnography. So just a bit I like to discuss about capnography. Capnography, you know, is the measurement of end-tidal carbon dioxide, and it confirms intubation. It is actually 100%, I can say, it is 100% confirmatory of intubation, 100%. So capnography is the measurement of end-tidal carbon dioxide along with this graph. And if the tube is in trachea, then only CO2 will come out of endotracheal tube, which you can measure. So it 100% confirm that the tube is in trachea. So since it 100% confirm intubation, so it should be able to detect accidental extubation. Accidental extubation means tube has slipped into esophagus or has come down. So what will be the value? Of course, the value will be 0. When the tube is not in trachea, from where carbon dioxide will come out, which you can measure. So obviously the value will become 0 and the graph is going to become flat line. So what are the conditions where EtCO2 becomes 0 and the graph is becoming flat line? Can you see? This is a normal graph. This is a normal graph, and all of a sudden the graph become flat line. No CO2 recording. And your record will also show here EtCO2 as 0. So the most important cause is tube has been extubated, or there is apnea. Apnea means no ventilation. If there is no ventilation, how CO2 will be produced? So again, it will become 0. Disconnection means tube get disconnected from circuit. So if endotracheal tube is attached to circuit, if it get disconnected, then how CO2 will reach monitor, which you can measure? So it will again become 0. Or endotracheal tube is completely obstructed. If the tube is completely obstructed, so how CO2 will reach the monitor? So again, it will become 0. So EtCO2 becoming 0, the conditions can be extubation, apnea, tube disconnection, or complete obstruction. And these are life-threatening conditions which are detected within seconds. So capnography is now mandated to confirm the position of endotracheal tube not only during anesthesia, even CPCR guidelines says that capnography is mandatory to confirm the position of endotracheal tube. However, the clinical best method to confirm the position of endotracheal tube is you can look at the chest expansion, and when you ventilate, both sides of the chest should expand, and you must confirm with auscultation. So you should be able to hear breath sound. But I told you, even auscultation can misguide you. Now, with this background, let's go back to the question again, and clearly says that develops left lung collapse. And on auscultation, breath sounds are only on right side. That means the tube has slipped into right bronchus. So right endobronchial intubation should be the answer. Question number 2. Patient undergoing surgery is administered succinylcholine for muscle relaxation. Shortly after administration, he develops hyperthermia, muscle rigidity, tremors, and tachycardia. What is the most appropriate treatment for this condition? Neostigmine, dendrolin sodium, atropine, midazolam. Again, a very simple, very straightforward question. After succinylcholine, patient developing severe hyperthermia, muscle rigidity, tremors, and signs of sympathetic stimulation, that tachycardia, the diagnosis is, of course, malignant hyperthermia. There is no second thought about that. So let's discuss a bit about malignant hyperthermia and then we'll come back to this question. So malignant hyperthermia, of course, as the name suggests, means the temperature is very rapidly rising, and it rises so rapidly that can increase by 1 degree centigrade every 5 minutes, and it can easily reach 110 or 111 degree Fahrenheit. So what are the causative agents in anesthesia? Succinylcholine is the most commonly implicated drug to cause malignant hyperthermia. Then all volatile agents, they can trigger malignant hyperthermia, but most often it is seen with halothane. So if they ask you most commonly implicated drug to cause malignant hyperthermia, it is succinylcholine. But if they ask you most common volatile agent to trigger malignant hyperthermia, then it is halothane. However, all volatile agents, that is halothane, isoflurane, desflurane, and sevoflurane, can trigger malignant hyperthermia. Clinical features: severe hypercarbia. CO2 can reach even 90 or 100 mmHg. So CO2 reaching so high, 90 or 100 mmHg, is only possible in malignant hyperthermia. And then you will see rapidly rising temperature. And I told you, temperature rise can be 1 degree centigrade every 5 minutes. And why actually malignant hyperthermia occurs? It is the abnormality of the ryanodine receptor, which is a calcium release receptor. Abnormality of the receptor lead to accumulation of calcium in sarcoplasmic reticulum, and that lead to sustained muscle contraction. And due to sustained muscle contraction, all bodies, they undergoes muscle contraction. So that muscle contraction will increase the muscle metabolism, that will produce a lot of heat, and that's why a lot of CO2 is also produced, and that is a reason that patient develop hyperthermia. So muscle rigidity is again a very important feature, and a very important clinical consequence is hyperkalemia. So much muscle metabolism will increase the potassium. So, and this increase in potassium can actually lead to cardiac arrest. Can lead to cardiac arrest due to ventricular fibrillation. So, increase in potassium or hyperkalemia induced ventricular fibrillation leading to cardiac arrest is the most common cause of death in malignant hyperthermia. Then, of course, there will be increased creatine kinase levels because muscle metabolism is so tremendously increased. So, of course, creatine kinase levels are going to be increased, like not only in thousands, they can reach even in lakhs. And eventually, later, patient may develop renal failure because this increased muscle metabolism will produce a lot of myoglobin, which can block the renal tubules, leading to renal failure. What is the management? The only specific treatment is dendrolin sodium. And dantrolene sodium, it directly acts as sarcoplasmic reticulum to block the calcium channels. So dantrolene sodium is the specific treatment. However, general treatment is very important. Like, for example, you have to hyperventilate the patient to wash out this carbon dioxide. Then you have to control the temperature by giving ice cold saline or covering the patient with cold blankets. Then you have to treat hyperkalemia because that can even cause cardiac arrest. Then you can expect a lot of acidosis, severe acidosis. That should be corrected even by giving soda bicarb. Then patient may go in renal failure, I told you. So you have to maintain urine output from the beginning. So now let's go back to the question and let's see. It's very simple. There's no doubt. Hyperthermia and succinylcholine. Following succinylcholine. So presentation after succinylcholine, patient developing hyperthermia, muscle rigidity, tremors. That indicates malignant hyperthermia. And I told you the specific management of malignant hyperthermia is dantrolene sodium. So the answer is B. Question number 3. Which of the following condition is not reversed with the administration of atropine? Bradycardia, muscle weakness due to neuromuscular blockade, excessive salivation, bronchoconstriction. Okay, let's go first for the discussion. So, what they are actually talking about reversal of non-depolarizers. We give muscle accent, and muscle accents are depolarizers and non-depolarizers. Non-depolarizers are used for surgical maintenance because they are long acting, and depolarizer, that is succinylcholine, that is used for intubation. So, what the mechanism of action of non-depolarizers? They are competitive antagonist. Competitive antagonist means they bind at the same receptor site at which acetylcholine binds, blocking the acetylcholine receptors. So, acetylcholine will not be able to act on that receptors, leading to relaxation. So, when you want to reverse the effect of non-depolarizer, it's a competitive antagonism, and a very simple principle of competitive antagonism is that it is a number game. If there are more molecules of acetylcholine, they will be able to replace non-depolarizer from their place. If there are more molecules of non-depolarizers, they will be able to replace acetylcholine from their place. So in the end, to compete with non-depolarizers, we have to increase the levels of acetylcholine, and that we do by preventing the metabolism of acetylcholine by giving cholinesterase inhibitors. And the most commonly used cholinesterase inhibitor is neostigmine. Neostigmine, although you can use pyridostigmine, androphonium, but they are not used neostigmine. So neostigmine will inhibit the cholinesterase that will prevent the degradation of acetylcholine. So there is more acetylcholine now available to compete with non-depolarizers. But the disadvantage, this neostigmine has increased the acetylcholine levels. So, okay, that will block the non-depolarizers. But the problem is that will cause muscarinic side effects. So, this increased acetylcholine is going to cause the muscarinic side effects. Muscarinic side effects means because this acetylcholine is not only going to act on nicotinic receptor, it will also act on muscarinic receptors. So muscarinic side effects means bronchospasm, increased salivation, increased secretions. So all these or even bradycardia. So all these muscarinic side effects will be there. So to combat these muscarinic side effects, we have to give an anti-muscarinic drug. So that can be atropine or that can be glycopyrrolate. However, nowadays you know that glycopyrrolate is always preferred over atropine. Why? Because glycopyrrolate does not cross the blood-brain barrier. So it has less CNS side effects and less cardiovascular side effects also. That is why, of course, glycopyrrolate is preferred. So whenever actually we say reversal, we say neostigmine plus glycopyrrolate. Neostigmine plus glycopyrrolate. That is the actual meaning of the reversal. So now let's go back to our question. So what they have asked in this question is which of the following is not reversed to the administration of atropine? Bradycardia, yes, it will be. It is a muscarinic side effect. Excessive salivation, yes, it is a muscarinic side effect. Bronchoconstriction, yes, it is a muscarinic side effect. Muscle weakness due to neuromuscular blockade is not reversed with atropine. It is reversed with neostigmine. So it is reversed with neostigmine. So neostigmine is used to reverse the muscle weakness by non-depolarizing muscle accents, while all other side effects they are reversed with atropine or glycopyrrolate. And as I told you, that glycopyrrolate is definitely preferred. So answer will be B. Again, simple question. If you know the concept of reversal of non-depolarizers. And yes, now we have another group of the drug that is called as gamma cyclodextrins. So they don't act indirectly. Neostigmine, we have seen act indirectly by increasing acetylcholine, while gamma cyclodextrins available in the brand name Sugammadex. Sugammadex is a very popular name. Sugammadex. So it directly bind to muscle accent and just form a complex, and complex is eliminated. But it is very expensive. Question number 4. A patient scheduled for elective hip surgery is currently taking aspirin, a multivitamin, enalapril, and metoprolol. The surgery is planned in 5 days. What is the appropriate perioperative management for this patient? Stop enalapril, stop aspirin to minimize perioperative bleeding risk, stop metoprolol to increase the cardiac output, increase aspirin doses for additional analgesic effect. Okay, we'll come back to this question. Let's have a discussion over it. See, management of pre-existing drug therapy is very, very important because every exam you are finding some question related to this pre-existing drug therapy. So drugs which need to be stopped, and these are the times before what time we have to stop these drugs. So whatever the drugs not mentioned here, these are the general drugs I'm discussing. That means they will be continued. Viagra or similar drugs, we have to stop 24 hours prior to the surgery. Why? Because these drugs cause a sympathetic stimulation, and surgery itself is a sympathetic stimulation. So we cannot further lead to sympathetic stimulation. Anticoagulants means mainly warfarin should be stopped 5 days prior. Otherwise, patient can bleed. Antiplatelets, aspirin, this is the latest guideline, to be stopped 72 hours before surgery, except recent MI, recent stroke, or corneal stent, where we continue. So these are the three conditions where we continue. Rest we have to stop aspirin 72 hours prior to the surgery. Clopidogrel, available in the brand name Clavis, need to be stopped 5 days prior to the surgery. Only high dose estrogen we have to stop 4 weeks prior because estrogen increases the risk of venous thromboembolism. So we have to stop 4 weeks prior. Only progesterone pills and low dose progesterone need or low dose progesterone, there's no need to stop. Herbal medications, we don't know the detailed side effects of herbal medications because in India not enough studies are there on herbal medications. So as a blanket, we stop 1 week before surgery. AC inhibitors, that is enalapril, captopril, or penidopril, and angiotensin receptor blockers, that is all sartans, valsartan, losartan, telmisartan, they need to be stopped 24 hours. Rest all antihypertensives we have to continue. Smoking, we have to stop 8 weeks prior. Why? Because smoking can inhibit ciliary activity. The recovery of that takes around 8 weeks. Morning dose to be omitted for diuretics if not taken for hypertension. Topical creams because they can have severe allergic reactions with the antiseptic solutions, and oral hypoglycemics. Then drug modifications are required. Cholinesterase inhibitors, and what are the modification required in cholinesterase inhibitor? Cholinesterase inhibitors means neostigmine, and obviously these patients will be myasthenia patients. So if you stop them, patient can develop myasthenic crisis, which is a dangerous complication. But if you continue them, then they can antagonize the effect of muscle accent. So we have to find the mid path, and mid path is continue but in reduced doses. Steroids, some modifications are required, but again that much details are not required for you. ATT, we continue subject to condition if patients lefty are normal. because ATT can affect LFT. So if LFT is normal, then only we can continue. So now let's go back to a question. What they have asked. Patient is on aspirin, a multivitamin, enalapril, and metropil, and surgery is after 5 days. So what is the perioperative management? Stop enalapril? No. It will be stopped one day before, not now. So that's wrong. Stop aspirin to minimize perioperative bleeding risk. See, yes, we stop aspirin, but actually not 5 days before, 3 days, 72 hours. I told you, 3 days. Stop metoprolol? Of course not. Increase aspirin doses? Of course not. So you can say, although this is not exactly correct choice, but the best choice among this is we have to stop aspirin 3 days, of course not 5 days, 3 days. Although some people they actually some books you may find 3 to 5 days also, but standard is 3 days. So that is the most choice which is most aligned or most nearest appropriate choice. So it will be question number 5. According to American Heart Association, what the fourth link added to the chain of survival? Rapid defibrillation, recovery and rehabilitation, high quality CPR, advanced airway management. You all know what are the four chain of survival. I means before 2020, there were three chain of survival, and that includes your basic life support. Then second is advanced cardiac life support, and then is the post cardiac arrest care. So that means basic life support means the life support which you can provide with the basic equipments or even without equipments. That means you can provide at roadside. Advanced cardiac life support means you are managing airway breathing circulation in a hospital setup with equipments and drugs. And post cardiac arrest care means when the patient is revived, what all parameters you have to take care in post cardiac arrest phase. So this is the standard. Now AHA 2020, they have added the fourth chain of survival, and that is recovery and rehabilitation. Recovery and rehabilitation. What does that mean? That does mean your job does not finishes once the patient is revived, and post cardiac arrest care means for say day or two you have taken care. No, patient during cardiac arrest would have suffered lot, maybe motor damage, sensory damage, psychological damage, or physical damage. So all that should have been taken care, and patient should be fully recovered. Then you say yes, you have done your job completely. So therefore they have added four chains of survival, that is a recovery. So that was again a very much expected question. So answer is B, yes. So one more thing I would like to tell here is changes in ASJ 2020. These two are the actually important changes. There are small changes also, but they're not significant. And I was expecting any question on that also. So actually, I was expecting more question on this, that they have changed the respiratory rate of pediatric patients. So pediatric patients, respiratory rate previously was like adults during CPR. Cardiac compression rate is 100 to 120 for all ages, and respiratory rate used to be 10 for children as well as adults. But 2020, they changed this 10 to 20 to 30. Now, during CPR, with the advanced airway I'm talking about, you have intubated the patient. One person will continue compression at a rate of 100 to 120 compressions per minute, while second person is going to give 20 to 30 breaths per minute. And there is no need for synchronization in between these two. However, for adult, this respiratory rate is 10 breaths per minute. So these were the only 5 questions. Have you got any doubt? Let me go to the link and see if there are any doubts. A live chat. Saurav Yadav says, sir, dental incorrect. Sir, can we get annotated PDF? I will send, I don't know how you will get it, at which group and everywhere. So just let me know where to send, no problem. I will send to someone. Annotated PP not an issue at all. Just let me know where to send. Whom should I give the annotated PPTs? So I will send, no problem, not an issue. PDF. Any other doubt or query? I'll just wait for 1 more minute. If there's no queries, then I'll close my session. Any doubt, query, or anything specific you want to know? No, okay then. I'm wrapping up the session. Okay, then my best wishes. Hope you all are going to come with flying colors and we're going to get score good. But anesthesia questions were really easy. Okay, then I'm closing the session.